this is the second series, which is organized by the Department of Community Medicine, Regional Feeds and the Training Division of NHM and DMO Kolla. In the first session last month, as you know, we deliberated on Omicron, what we know and what we don't know. And today we are in the midst of Omicron wave. For the second session, we have selected the topic COVID-19 vaccine updates and understanding the immunology to decide further strategies. As everybody knows, the 16th January 2022, that marked the 1 year since we began the vaccination drive against the COVID-19. And we have successfully covered almost all adult population in the state and with at least one dose of COVID vaccine. We have begun the administration of precautionary dose and vaccination of children between the age of 15 to 18 years. The role of vaccination, as you know, it is very crucial in reducing the rate of disease as well as the mortality. So we are in the forefront fighting this long battle against the viral infection. An updation of our understanding of vaccine and immunology of infection is essential, and it is the need of the time. And to enlighten us on this topic, we have a very eminent personality with us today, Dr. Jagdeep Kang. Dr. Kang is the professor and head of the department and professor of the Department of Gastrointestinal Disease at CMC Vellore, and she is an ex officio member of WHO's working group on COVID-19 vaccine. She is a leading researcher on viral infection as well as enteric infection in particular. Dr. Kang was among the principal investigators on the trial of Rota vaccine. She is the first Indian to be appointed as the faculty in several international universities of repute, and she is selected as a fellow of Royal Society, and she holds many honorary appointments. I have a great privilege in extending a warm welcome to Madam Kang. Now, next I invite Dr. Asha Thomas, our additional Chief Secretary, and she consented to attend the meeting even though she is having busy schedule, and she has strongly supported us in this venture, and she actively participated in the last session also. I welcome you, madam, and thank you, madam, for joining us. Next, I welcome the Principal Secretary of Health and Family Welfare, Dr. Rajan Sir, and Sir has agreed to join us despite his busy schedule. We have an expert panel to discuss Omicron wave in Kerala. Dr. Ramla, actually, I call her as mother because she is guiding us, and she is our director and of medical education, and she has kindly consented to attend the meeting. I welcome madam to this session. Next, I welcome Dr. Raju. He is the Director of Health Services of Kerala. I welcome you, sir, to our session. Next, Dr. Thomas Matthew, sir, our Joint Director of Medical Education and a well-known clinical epidemiologist, as well as he is also from community medicine. We have been in constant interaction with him, and he is a support to all of us. Recently also, he gave me a lot of support to run our hospital, especially Medical College Kollam. Next, I invited Dr. Bindu Mohan. He is the District Medical Officer of Health. I welcome her to this session. I also extend a warm and welcome to Dr. Reena KJ, who is the Additional Director of Health Services, and Dr. Meenakshi, another DHS. Now, I also welcome Dr. Sandeep K, Deputy Director of Family Welfare, Dr. Sandhya R, DSO of Kollam, and Dr. Aravind R, Head of Infectious Diseases. Actually, he was with us for the last session also. And but the least, and it is not the least, I welcome all participants who have kept apart precious time to attend this meeting. Thank you all once again. A warm welcome to all. Let me conclude my words. Thank you all.
Thank you, sir. As sir mentioned, we have scheduled today's program in 3 parts. First, let's listen to Dr. Gagandeep Kang. Then we have policymakers in conversation with Dr. Kang. Dr. Asha Thomas, our Additional Chief Secretary, has already joined. We are expecting Dr. Rajan Kobragade also to join, and finally the panel. First, let's listen to the most awaited talk and one of the most popular faces in COVID times, Dr. Gagandeep Kang.
Thank you very much, Indu, for the invitation, and I hope you will be able to see my slides. So I'm going to be talking to you about COVID-19 vaccines. It's a huge area, so I'm not going to try and cover everything, but I hope that during our discussions, if there are missing things that you would like to discuss in more depth, we will be able to go there. So just to start, this is our world in data showing us where we are. And if you look at the figures for the daily new confirmed COVID-19 cases per million, you can see that the waves that we've seen previously look really small in comparison to what is happening now with Omicron. Fortunately for us, if we look at the severity of disease, we can see that there has been a decoupling between cases and deaths, because the number of deaths that occurred in prior waves in multiple countries were very, very different from the ones that we are seeing during this current Omicron wave. And that is a situation that tells us. So we've wound up with a variant where cases and deaths are not tracking together. And this is really interesting because the fact that the variant is able to cause so many infections when so much of the world has already been infected or has been vaccinated shows us that this is a variant that is capable of great immune escape. Nonetheless, despite the fact that it is evading immunity, it is not causing severe disease, and that's a matter of great relief for us. Now, I know we talk a lot about how well India is doing in terms of vaccines. If we look at the world, we have given out 1.6 billion doses of vaccine. And that is an incredible achievement. But we also have to remember that the size of our population means that if we have a map of the world that looks at where the unvaccinated population is, India is the country with the largest number of unvaccinated people in the world. So that's just to remind ourselves that we still have some ways to go in reaching parts of the population that we have not reached. Kerala is doing a great job, but not every state has been performing in the same way. And we have to remember that under 15s are not vaccinated at the moment, and we should think through what our strategies need to be for them. Now, when WHO made its recommendations for vaccines, and what WHO is aiming for is 70% coverage around the globe by the middle of 2022. They want for COVID-19 vaccines to be a global public good. And this figure, the map, shows us that this is not a global public good. The West and North seems pretty well covered with vaccines. But if we look at what's happening in Africa and in low-income countries, it doesn't seem as good a picture. So what we want is for vaccines to be available and used by everybody. Looking at our world in data today, you can see that India is above the global average. Just between India and the world, there is Mexico. These, if you want to just look at the numbers and figures, remember that this is for the total population, not for the total eligible population that has been covered. So if we look at the world, 61% of the world's population has received at least one dose of the COVID-19 vaccine. 10 billion doses have been given globally, and about 25 million doses are given each day. This is a drop from the start of the year, where about 34 million doses were being given. So we seem to be reaching a stage where high-income countries have reached the level of saturation that they are likely to reach with their booster doses. And our own programs are plateauing. And in low-income countries that don't have high coverage, we haven't been able to pick it up. So about 10% of people in low-income countries have received at least one dose of vaccine as of today. And that's around 30 countries in the world have low doses. This is figures from a couple of weeks ago, where if you look at China, it had at that time given out 2.9 billion doses of vaccine, mostly vaccines produced in China, mainly the inactivated ones. And they are also now looking at boosting subsets of their population. In India, we are now at 1.6 billion doses. And then, of course, no other countries in the world need more than 1 billion doses of vaccine. If we look at vaccine doses administered as a proportion of the population, you can see that there are several small countries that have done incredibly well in covering their populations. Now, what has changed in the world and what we are discussing is this new variant, which is Omicron. And this is data showing the SARS-CoV-2 sequences by variant for the preceding 2 weeks. If you look at India, which is just below Indonesia on this map, you can see that 95+% of the variants that have been sequenced in India are currently Omicron. So there's very little Delta left. And if we go in the same direction as countries like the United Kingdom, Canada, United States, etc., those proportions will decrease even more. We will have less and less of anything other than Omicron. And it's not going to take very long. Now, coming to how vaccines are performing, what I'd like to do is share with you data. And the best data on how well vaccines are doing comes from the UK. Just to set up this slide, in the gray circles, you have Omicron. In the black boxes, you have Delta. And what you see here is in the first box, this is the effectiveness of vaccines by time, 2 to 4 weeks, 5 to 9 weeks, 10 to 14 weeks after the second dose of the AstraZeneca vaccine. Then you see the dotted line, and the dotted line shows you when there was a booster of either the Pfizer vaccine, BNT162b2, or of the Moderna vaccine, which is the mRNA 1273. So baseline, first 2 doses, AstraZeneca, same people boosted with either Pfizer or Moderna. What happens to them? Well, they compared about 250,000 Delta cases with 750,000 Omicron cases. So incredible numbers being analyzed there. And what you see is that vaccine effectiveness in the prevention of infection with the AstraZeneca vaccine declines from just over 40% to nothing. If you are 6 months beyond your AstraZeneca dose and infected with Omicron, you have about 0 protection. If you have gotten to that point with only 2 doses of vaccine. The same situation for Delta, you would have had about 40% protection from infection. Let's remember, infection and hospitalization are two different things. Then if you get boosted against Delta and against Omicron, you get really good protection. However, that protection peaks in about a month and starts to drop again. You still have about 45% protection, 45-50% protection at 10 weeks post the booster. So this is baseline of AstraZeneca looking at protection from infection. If we look at these figures, these two figures, the top one is for the Pfizer vaccine, set up the same way, 2 doses of Pfizer vaccine, what happens with Omicron and with Delta, and then what happens if you get a booster of either another Pfizer vaccine or a Moderna vaccine. And in the bottom graph, you have the same thing. You have 2 doses of the Moderna vaccine, and then you get boosted either with the Pfizer or the Moderna. What do we see here? We see that the mRNA vaccines are performing slightly better than the AstraZeneca vaccine when it comes to protection from infection. We saw that 20 weeks, 25 weeks after 2 doses of the AstraZeneca vaccine, we had 0 protection against infection. However, with the Pfizer, you are just below 20%. And with the Moderna, you're at about the same for Omicron. So some protection persists. When you boost, you get much higher protection with the Pfizer and the Moderna vaccines, about 70% with Pfizer and about 80% when you had a base of the Moderna vaccine. So this was data against infection. Now, recently, there has been a lot of interest in what's happening with the subsets of Omicron that are circulating in different parts of the world. And these are data that were released yesterday by the UK Health Security Agency comparing BA1 and BA2. And essentially what they show is if we are looking at protection against symptomatic disease, there is no difference between BA1 and BA2. There seems to be a slight, very slight transmission advantage with BA2, but it doesn't seem to be escaping the immune response better than BA1. Now, coming to protection against hospitalization with Omicron, what happens with 1 dose, 2 doses, or 3 doses? And here the data are combined for all the vaccines, AstraZeneca, Pfizer, and Moderna, because there weren't enough numbers to be able to analyze these separately, but those data will also emerge. What I'd like you to focus on are the first 2 columns and then the last column. The first column shows you the number of doses, 1 dose, 2 doses, or 3 doses, which is boosted. And then you have intervals after doses, which is 4 weeks, 2 to 24, beyond 25 weeks. And then because the booster timings are fairly recent, the time divisions are 2 to 4, 5 to 9, and more than 10 weeks. And now let's look at the last column, hospitalization. What is the vaccine effectiveness? So 4 weeks after you receive a single dose of vaccine, you have 58% protection. If you get 2 doses, it's 64%, but it declines after 6 months to 44%. And if you get 3 doses, this is looking specifically at protection from Omicron hospitalization. If you get 3 doses in 2 to 4 weeks, you have 92% protection, 2 to 4 weeks after your booster dose. 5 to 9 weeks, it's 88%. So 10 weeks, it's 83%. So you can see that it has begun to drop very, very rapidly. So, but the important thing also to remember is the UK age structure is very different from ours. Their pattern of comorbidities is different. Their infections previously are different. So, and these are small numbers that we are talking about. So the pattern is what we should look at. It tells us that you get reasonable protection against Omicron with 2 doses shortly after immunization. But after 6 months, that protection drops to 45%. If you give a booster dose, you will boost that protection, but that will also decline with time. Now, there is another study from the UK that I thought would be useful to share, and this is the Siren Study. It has 44,000 healthcare workers. They are screened for infection, symptomatic or asymptomatic, every 2 weeks. And in this group, 30% were seropositive at baseline, and 95% of them have been vaccinated. So you can look at the top graph, which shows you the positive PCR tests in that population. You can see that with Omicron in December, the numbers just go shooting up in terms of the number of people that are infected. Okay, so now because it had 30% of people who were seropositive at baseline, and they have been tracking infections during the entire time that the Siren study has been going on, it's possible to look at the protection from vaccination and the protection from vaccination and infection. So here, let's look at the data. The first 3 rows with numbers there are uninfected people who have been either not vaccinated, very small numbers, or vaccinated with 2 doses, or vaccinated with 3 doses. And then in the lower 3 rows, you have people who have been infected and then who are unvaccinated, vaccinated with 2 doses, or vaccinated with 3 doses. And this is looking at the incidence of Omicron infections in the Siren cohort. Now, if we look at vaccine effectiveness, we won't look at the 95% confidence intervals. You are comparing to unvaccinated, uninfected people. You see that vaccination with 2 doses gives you an effectiveness of 32%, with a booster dose that goes up to 62%. However, if you are infected but not vaccinated, you have a protection of 44%, with 2 doses that goes up to 60%, and vaccinated with infected, vaccinated, boosted gives you 71% vaccine effectiveness. So essentially what you're seeing is that in people who have infection plus have received 2 doses of vaccine, the level of protection that they have is similar to those who were not infected but received 3 doses of vaccine. So infection is like an extra dose of vaccination in terms of protection with Omicron. Okay, so I'm going to come now to Omicron itself and why we need detailed studies on this. You will remember that very early on, we got data on neutralizing antibodies, essentially showing us that there was a huge drop if you took people who had been vaccinated with the Pfizer vaccine, or vaccinated and infected. Vaccinated and infected shown in the green, and vaccinated alone shown in the orange in the figure there. What you see is that there was a massive drop in the ability of the sera from those individuals to neutralize the Omicron variant. And if you looked at the variant, it looked like the variant had everything that was possible to be dangerous, to have immune escape. So if you just compare Delta, the Delta spike with the Omicron spike, you can just look at it and see how many more mutations there were in Omicron. Now, another good way to be able to look at the level of immune escape is something called Antigenic Cartography. And if you look at the little colored bubbles that are shown on the bottom of this slide, what you see here is basically different variants, what is the distance between their antigens? This is looking at the spike protein of different viruses. So you have beta gamma on one side, you have alpha, which is quite close to Wuhan. Then you have delta, which is a little bit far away, shown in the bright pink. And then you have the Omicron at a long distance away, shown in the gray. So this just shows us that Omicron is very different from the ancestral virus that we had, and is also very different from the variants that we have seen before. And this explains the level of immune escape that we see in the Omicron variant. Now, if we look at fold reductions in neutralizing antibodies, this is in vaccinated people. What you see here in each column is each of the variants, alpha, beta, gamma, delta, Omicron. And each of those boxes is a vaccine platform. Inactivated, mRNA, protein subunit, vectored, all booster schedules that people have had. And what you're seeing here is fold reduction in the ability to neutralize. So the higher up the boxes are, the greater the level of reduction of neutralization. Close to the bottom means good neutralization. Going up on top means poor neutralization. What you can very clearly see from this is that Omicron, among all of the variants, is the one that has the greatest reduction in the ability of people who have received these vaccines to neutralize the Omicron variant. Okay. Now, this was for people who had received the primary series. And you can see here from the figures the number of studies that have been done and the fold reduction in the neutralizing antibodies. And you can see that it varies from 8 to 86 times reduction in different studies. Now, if we look at booster doses, what do we see? Again, towards the bottom, retaining neutralizing ability, towards the top, having lost neutralizing ability. And you can see that with Omicron, there is now a variation across platforms, but essentially what we are seeing is there continues to be a reduction in the ability of even booster doses to neutralize the Omicron variant. Now, if all of our immune response, all of our protection was dependent only on neutralizing antibodies, based on this data, we'd be in very serious trouble. But fortunately, there are data that show us something different. Before I come to the T cell data, I'd like to show you data from this truly beautiful study, where essentially what they did was they collected samples from people who were infected with different variants of the virus. So we've seen the vaccination data. Now we are looking at infection data. These are people who were infected early in the pandemic in the UK, infected with the alpha variant, infected with the beta, gamma, delta variant, and vaccinated people infected with the delta variant. So those are your figures A to F. Now what we are looking at is what is the ability to neutralize these variants in people who we know were infected with these strains. So if you look, the different colors that you see there are the different variants. Omicron is shown in black and Delta is shown in purple. So you can see that where you have an infection with alpha, you're making pretty good antibodies against alpha. But those same sera don't make as good antibodies against the beta, right? Basically, across all of this slide, what it's showing you is that whether it was vaccination, which we saw previously, or infection, which we are seeing now, the ability of pre-existing antibodies to neutralize Omicron is a lot less. Okay. However, when you give a third dose, your antibodies do go up. They go up against all of the viruses, whether it is Omicron or Delta or Victoria, which is the ancestral close to the Wuhan strain. The third dose does boost neutralizing antibodies. Nonetheless, if you look at the scales on this, there is a gradation where Victoria boosts most, Delta boosts next, and Omicron boosts about the least. Now, everybody is also interested specifically in Covaxin and Covaxin's ability to neutralize. And these are data from the Emory Vaccine Center that was sent sera from people who had been receiving the Covaxin vaccine in the phase 2 trial in India. And here the sera were collected after the primary series and after a booster dose. And essentially what this study showed was that there was a reduction in the ability to neutralize the Omicron variant as compared to Delta or the vaccine strain, which was a D614G. But there was some level of boosting with Covaxin also. Now, coming finally to T cells, there are studies that explain why we are not seeing, despite the fact that neutralizing antibodies have come down a lot, we are not seeing a serious issue with the Omicron variant. And essentially what we are seeing is that CD4 and CD8 responses that have been induced by either vaccination, and this study is with mRNA vaccine, or by infection, are protected. So the protection from, the CD4 responses and the CD8 responses, when you look at the breadth of responses that are available, 84% and 78% of what has been induced by infection still works in terms of recognizing epitopes, and 91 and 92% for mRNA vaccines. So functionally, really very little difference. So this is just the data here. I think if you just look at the column, the first set of figures after the flow figures that show you vaccinated and convalescent, you see that in people that are vaccinated, there is 91% retention, 9% loss. And in convalescent individuals, there's 84% retention or 16% loss. And similarly for vaccinated and convalescent for CD8 responses, you see an 8% and 30% reduction in response. So not huge reductions in response. Now, WHO has just come out on the 21st of January with a revised roadmap for vaccination. I had mentioned that they said that WHO has recommended that we should get 70% of populations in countries vaccinated by the middle of 2022, and obviously India will exceed that figure. But I think it's important to understand that a lot of modeling exercises have informed this WHO effort, and the key recommendations are that within a priority group, and I'll come to what the priority groups are, making sure that primary vaccination is done first is better than trying to increase boosters. And across priority groups, you have to make sure that in a country, the highest priority group should get the booster doses before lower priority groups. So there are challenges, obviously, for programs in ensuring that priority groups are identified and vaccines can be delivered to them. Maybe I won't walk you through this slide, but I will take you to this figure, which essentially summarizes the priority use groups by WHO and what they are saying about when you should use this. And this really looks at two things. What is the priority for severe disease and for infection? And here you have older adults, healthcare workers, and immunocompromised people in the first group, followed by people with comorbidities, pregnancy, teachers, essential workers, etc. So when you have low vaccine supply, you should make sure that the highest priority group starts to get vaccinated. When your vaccine supply is moderate, then you can come into group 3. When your vaccine supply is high, then you come into, you come into group 2 when you have moderate supply. When you have high supply, you come into group 3, which is your medium priority group. And when you have very high excess of vaccines, then you can think about the lowest priority use group also getting vaccines. And then once you've started the primary series, then you can think about additional doses and boosters. So just to summarize, where we are today is Omicron has led to an emphasis on booster doses around the world. From South African data, we are unclear about whether boosters really made a difference or not, or whether it was infection and the combination of vaccination and infection that made a difference. The new WHO roadmap provides guidance that does include boosters by priority groups and coverage. We know that if you give a third dose, it does result in a boost in neutralizing antibodies. We know from the UK that a third dose does contribute to reduced hospitalizations, but as yet, we don't have the broken down data that shows us how much of a difference it makes by age, by priority groups, etc. So in general, it seems like for the highest priority groups, boosters are justified at this time, and we do need to think about where we are going with boosters in the future. I'll stop there and thank you.
Thank you very much, Dr. Kang. We have a lot of questions coming up, but before we take up questions, we have a conversation between the scientist and the policymaker. Dr. Asha Thomas, our Additional Chief Secretary Health, is also a medical doctor herself. She's also a researcher. She did her MBBS from Government Medical College, Trivandrum, one of the senior most IAS officers in the state. And she's also a researcher. She was a scholar at the Johns Hopkins. Madam.
Thank you, Dr. Kang, for a brilliant and absolutely succinct layout of the vaccine scene at the moment. And as you know, we have come through 2 waves of COVID. We are in the 3rd. Starting from the beginning, Kerala being one of the earliest states to report COVID. I remember the early days when we really didn't know what was happening. And we went in through this whole time when all we were doing is searching the internet for information and brainstorming and trying to use our common sense, if nothing else, to figure out what to do. I remember there was a time when when I was searching the internet to understand what is the material used for a PPE kit, because we thought we would have to manufacture PPE kits locally, and we were trying to figure that out. I remember trying to understand what the concept of lockdown was, something I had never even thought about before, and trying to figure out what it meant for the people. Everything from modeling, it was a whole new idea, and so many people coming out with different models. But in the final analysis, I also realized that most of what we did, especially the use of data, did not really materialize into evidence-based policy in the long run. After a while, when the national agencies took over, we became our data was used more for justifying what we are doing to the public rather than really driving a customized response at the ground level. So at this point, when we are still apparently playing catch up to the virus, Mike, I would like to hear from you whether all of this, does it mean that we will ultimately, because you were presenting data up to 10 weeks, I would like to know why, I mean, is it that we do not have long-term data to know what will happen after 10 weeks? Are we limited by our time that we do not know that? And if so, can you predict, can you throw in your own predictions at this moment, whether we will ultimately go to the point where we will be taking annual flu shots, like flu shots, we'll be taking COVID shots every year, like a seasonal infection. And another thing I would like to understand from you is, this is a curious question. You showed us a lot of data from the UK, from the US, and various other sources. Why is it that there was no Indian studies mentioned? Is it that we are not doing it, or is it, I mean, I would really like to know why there were no Indian figures. I know that there are collaborative data, you mentioned that there is, but an actual study or something that came out of India, I would like to know why that was just not there. And the third thing I'd like to know is whether, if in fact, as I said, we'll be reduced to taking COVID shots every year, do you think we would ever get the cost of vaccines down to a more reasonable level? Or is this likely that we may have to change our vaccines in coming years to cope with it? Or would it be the same type of vaccine going on, and hopefully the generic versions coming out, can we be bringing down to a much cheaper level? So since this is supposed to be a conversation with you, that's why I'm posing these questions. So I'd like to know how you feel about that.
Thank you very much, Asha. I think all of these are really important questions. Let's start with the first one about timing and why we don't have data of more than 10 weeks. Because the data that I was showing was relating to Omicron, and it seems incredible, but we've had Omicron only for 10 weeks. So, as time goes on, more data about the duration from vaccination to protection from Omicron will become available. But right now, Omicron's data is just over 2 months. So we can't say protection against Omicron for longer than 10 weeks. As that appears, we'll collect that information. And the UK's Health Security Agency has been phenomenal about very timely analysis and sharing of data. So in a sense, in learning from the world, we've been quite fortunate to have first the South Africans to share data so quickly, and then the UK to be able to analyze their own data and tell us about how vaccines are doing very quickly as well. And this, you asked about boosters and whether we'll wind up in a flu-like situation. It's an interesting question that I don't think anyone can completely answer yet. So I will give you what I think is my opinion. I think for SARS-CoV-2, we are going to wind up with two sets of people. People whom we know are clinically vulnerable. So the elderly, and for me, that's really people over 70 and not over 60. People who are immunocompromised, people who have comorbidities that actually depress their immune response. Those people will be people for whom we will need to monitor immune systems, antibody responses, and potentially think about boosters on a fairly regular basis. For most people who are healthy, I think 2 doses, a maximum of 1 booster is as far as we are going to need to go. Because even though I showed the antigenic cartography, the map of the antigens showing how far away Omicron is, the fact remains that our T-cell responses are preserved. Neutralizing antibodies are important for preventing infection. What we are seeing with Omicron is that there is escape from prevention of infection. So the neutralizing antibody drop that we see with Omicron has a functional consequence in that reinfections are happening. But severe disease is not happening. And severe disease happens when the virus gets inside cells, destroys cells, and goes to other places. That doesn't seem to be happening. And two reasons for this. One is the preservation of the T cell response. And the second is that this infection is limited largely to the upper airways. So I think we got lucky in the location and in the preservation of the T cell responses. So for booster doses, I think we will dichotomize the population and subsets may need boosters. So we were talking about cost of vaccines, and India has the capacity to make the cheapest vaccines in the world. Our network of developing country vaccine manufacturers have driven down prices across standard platforms for all vaccines that are widely used. With the prices that the vaccine manufacturers have been charging the government, they've actually been making a profit. For both the inactivated and the Covishield vaccine, I think we could have done a better job of negotiating, especially given the volumes of vaccine that we have been buying from them. We bought more than 1 billion doses of Covishield. That's incredible. And there's no reason that we should have paid what we paid for it. We, in fact, paid a price that was slightly higher than AstraZeneca charged for the COVAX facility. So some rationalization has to be done. Your last question was on research and data. Why no data from India? Well, that's a story after my own heart. As in, India has a lot of data. We established a lot of different kinds of databases, but we never ensured that the databases could talk to each other. So you can't link the COVID data to the ICMR's testing database, and you can't link that to the information that the Ministry of Health and NCDC have. And you actually need all the databases to talk to each other so that we know what happened to individuals. If someone got hospitalized, had they been vaccinated? With which vaccine? How long ago? And there's no way we can capture that information without the linking of databases. But I think even if we were to say, okay, let's wipe the slate clean and start now capturing information that has one unique identifier across all the databases, we can generate incredible amounts of data in this country. We just haven't had the will to do that so far. And that's why we wound up with these little studies. My hospital, AIMS, small studies, 1,000 people, 10,000 people. And healthcare workers are a special population in terms of exposure, in terms of being occupied. So what data is generated in these populations cannot be extrapolated to the general community. So whenever people ask me, but there are data from India, but my question is, what do these data represent? The 1 crore healthcare workers that we have? What about the rest of the country?
Let's begin with a question from Dr. B. Iqbal. Iqbal sir is the chairperson of the expert committee on COVID for the government. Will infection with Omicron protect against Delta? Iqbal sir, would you like to unmute and speak, or shall we go to your answer?
So thank you, Dr. Iqbal. In terms of neutralizing antibody response, there are data that were generated quite early on that showed that infection with Omicron did result in an increase in the ability to neutralize Delta as well. So this was shown first in studies from the UK, and this last week has been confirmed by studies from ICMR as well. Will this play out in a clinical situation? I see no reason why it should not. There are also previous data that have shown that if you had SARS-CoV infection, which is the original SARS, you actually had some level of protection against SARS-CoV-2. So these viruses are related. And when we begin to think about universal vaccines or second generation vaccines, then understanding immune responses and the ability of these vaccines to generate either humoral antibodies or cellular immunity, then the breadth of those responses becomes critically important.
Thank you. Now we have a question from Dr. Purushothaman, Professor of Pediatrics. Third dose with any of the vaccines gives higher level. So we infer that it's beneficial. How long will it last? A situation where the neutralizing capacity is 1/10 instead of 7 weeks in the original strain, we may get protection just a few weeks.
So
is there an evidence that cell-mediated immunity protects?
Well, it's very difficult to have a person who has cell-mediated immunity with 0 antibodies. There are some studies that have tried to identify these individuals. So people in whom binding antibodies are low, neutralizing antibodies are not present, even if they have been vaccinated, and then look to see whether they have a T-cell response and whether they are protected. Finding those individuals is hard. We've gotten to the point of demonstrating that you can have a T-cell response in the absence of a measurable antibody response. Now, does that T-cell response also protect? We are still looking for sufficient numbers of people to be able to generate that information.
Dr. Aravind, Head of Infectious Diseases. Will infection with BA1 protect against BA2?
It doesn't look like BA1 and BA2 are very, very different. So I think it's likely, but at the moment, we don't have that data. We actually have very little data on reinfections with Omicron. So does an Omicron infection protect against a subsequent infection with Omicron? Our experience with this variant is very recent, so hard to generate information that quickly.
Dr. Divya, is there a chance of intracranial bleed after Covishield vaccine for the elderly?
So actually the elderly have lower level of risk with the Covishield vaccine than younger individuals. I think it's very important to emphasize that the thrombosis with thrombocytopenia syndrome is actually an autoimmune phenomenon where pre-existing antibodies to platelet factor 4 lead to the thrombosis and lead to capture of platelets. So this is a very special situation. It's not every thrombosis and every bleed. But it also has an age specificity, which is that you see this condition in response to vaccination more in a younger population than in an older population. This is the reason why many countries stopped using this vaccine in their younger populations, but continued to use it in people over 40 or over 50. Now, that said, it is a rare thrombosis with thrombocytopenia syndrome is a rare phenomenon. The highest rates are reported in Australia. And in Australia, the mortality rate for TTS that is diagnosed is 3%.
Is booster dose required for Sputnik vaccine?
I think we should not differentiate Sputnik from any of the other vaccines that we have. There is very little independent data on Sputnik. All of the data that we have has come from people who were involved in the making of the vaccine. So with any vaccine, when you want to see real world data, you want to see that real world data independently generated. We have not had that with Sputnik, but there is no reason why Sputnik should not require a booster dose if 2 doses of other vectored vaccines require a booster dose.
Dr. J. Kumari from Endocrinology. Is it good to take 2 doses of Covishield and 1 dose of Pfizer?
Yes. So that is something, it's nice when you actually have data and you can say yes confidently. So data from the CovBoost study shows that if you have 2 doses of the AstraZeneca vaccine and then you get a dose of the mRNA vaccine, you get at a population level an increase in antibodies of almost 25 times. That's the biggest boost that you can imagine.
Is isolation and in hospital really needed?
Depends on who you are protecting and the circumstance. So if you think about people who are symptomatic, right? If they can isolate at home and can be managed reasonably at home, there's no need to isolate them in a hospital. However, if you have individuals who have immunocompromised people at home, then removing them from the home may make sense in order to protect the immunocompromised individual.
Dr. T.K. Suma, Professor of Medicine from Alleppey Medical College. What about reinfection with BA2 in those who already had infection with the previous variant?
We have no idea. We have not seen any cases of BA2 causing an infection in people who have had BA1. And remember that this would be a relatively rare circumstance in any case because it would require genomic sequencing of both the isolates. And we know that sequencing is happening at very low levels right now.
Dr. Riaz from Pediatrics. Is it time for a country to start childhood vaccination?
Tough question. I think that we have 60% of our children, much lower in Kerala, were already antibody positive in June, July last year. So those children already have exposure to the virus. Should we vaccinate those children or let them get infected again, which is likely to happen? Most of these kids were asymptomatic when they were infected the first time. If they get infected again, the likelihood is that their second infection will also be asymptomatic. And over time, they'll have multiple infections and their antibody responses will boost. Shall we preempt that by giving them a couple of doses of vaccine? Well, it's not a wrong strategy to undertake, but my question is, which vaccine? Do we know which is the best vaccine for children? Should we be using the mRNA vaccine like the West? Because nobody is giving inactivated vaccines to children except us, right? So poorer countries are using the inactivated vaccines. Richer countries are using the mRNA vaccines. Nobody is using the viral vectored vaccines in children. So I think we are fortunate in the situation that children are handling this disease well. So for children who are immunocompromised, who have comorbidities of various kinds, I absolutely think that any additional protection we give them with vaccines is worthwhile, while we figure out what we should be doing to define what is the best vaccine and best vaccination strategy for children. I don't think we have clear answers to that. I know WHO is recommending that we should be thinking about vaccinating children and even thinking about booster doses in children. But that is a large global recommendation and does not take into consideration the availability of the vaccines that we have in the country and the infection history of our children.
Dr. Senior from Community Medicine. Is there a difference between infections prior to vaccination and after vaccination in terms of effectiveness?
So, short answer to that is it looks like, at least for Omicron, an infection is as good as one dose of vaccine. However, for Delta, infection was better than vaccination in terms of protection from severe disease. And that's clear from data that has come out from the US in a very, very large study. If you were infected, you actually had better protection than if you were vaccinated.
What about post-COVID syndromes in Omicron infection among the vaccinated?
We don't know about what's going to happen post-COVID. We saw the incredible number of cases and infections that we are seeing around the world. Now, will this result in lots of post-COVID, long COVID, and will that then be a huge burden that our health systems have to handle? We actually don't know if that is going to happen. There does not appear to be a relationship before this of severity of disease with the occurrence of long COVID. You could have it if you had mild disease, you could have it if you had severe disease. What will happen with Omicron, we don't know yet.
Dr. Tanuja from Obstetrics and Gynecology, the precautionary dose in pregnant women.
So assuming that your pregnant woman has been vaccinated previously, currently she's not going to be eligible for a precautionary dose if she is a woman in the reproductive age group. Am I missing something?
Okay. Since a large majority of patients are asymptomatic, is it any more beneficial in segregating patients into COVID and non-COVID areas? Isn't it practical to treat all patients in common wards while maintaining precautions, so that only the obviously symptomatic patients need to be tested and shifted to COVID-specific wards?
Well, I think if you're going to have people who are very susceptible when they have if they get an infection, it's going to lead to a very poor outcome in them. Then figuring out a way of protecting them makes sense. So if you are looking at cohorting COVID patients, which is what is currently happening, that you have COVID wards and non-COVID wards, I think the important thing to remember is that with a variant like Omicron, your chances of picking it up, even in your non-COVID wards, if you're not testing frequently, is relatively low, and you may have transmission there. So you have to think about the reasons why you want patients separated out.
Whether pre-existing adenovirus vector immunity interfere with booster dose effectiveness in case of booster with Covishield?
We saw from the CovBoost study that that did not happen. So one of the reasons that people worried about prior antibodies influencing subsequent doses and the immune response to those doses was because a lot of the original adenovirus vectors were based on viruses that were circulating in humans. Covishield is a non-replicating adenovirus that came from animals and was designed to be non-replicating, and an animal virus was chosen so that you could work around this problem of reduced immune responses to a vector, to a virus which people had high exposure to previously. That has been kind of validated by the CovBoost study, where you get a geometric mean ratio of 3.25, demonstrating that a third dose of Covishield in people who have received 2 prior doses of Covishield does result in an increase in the immune response.
Dr. Devraj from Community Medicine, shouldn't we have a policy to give third dose to all?
I'm not sure. I wouldn't agree with that, because quite frankly, I trust our immune systems to do a reasonable job. I think the first couple of doses of vaccine are essential. We must get those out to everybody. But if they modify disease enough that it becomes mild, then I think a boost that comes from natural infection is likely to give you a broader, longer lasting immune response than a third dose of vaccine.
Dr. Padmanabh Shenoy is suggesting, if time permits, he would like to share Omicron neutralization from our lab, his lab. Actually, Dr. Shenoy, Dr. Kang, shall we give him a few minutes?
Oh, absolutely. Always love to see Dr. Shenoy's data.
Yeah, can you hear me, ma'am? Can you hear me?
Yes, Dr.
Yeah. There are certain things. Basically, we had done Omicron neutralization yesterday. So it's a preliminary data, but it's very interesting. What, as expected, Covishield and Covaxin, and at the outset, our data is in autoimmune rheumatic disease patients. So, so we cannot generalize to the population, but it is interesting. In Covishield and Covaxin, both of them are, which are very well neutralizing the Delta. Especially Covishield is neutralizing Delta very well. And we have in the previous paper, which is already published, shown that it is in Covaxin is not able to neutralize the Delta variant. And same thing, Covishield, the Delta neutralization comes to a great extent, comes down by a great extent, as you showed. But what is very interesting, what we found was that hybrid immunity, for example, infection followed by 1 dose of vaccine or 2 doses of vaccine, is holding on against Omicron very well. Like Delta, although there is some 20% dip in neutralization, it is holding on very well. But Covaxin, unfortunately, fares very badly. Those who are having Covaxin hybrid, for example, infection followed by Covaxin, the neutralization is pretty bad. So that's what a bit worrying. But and second thing, what we have done recently was in the previous cohort, what we have published, we have shown that B cell immunogenicity of Covaxin is pretty low. In 60% of them do not produce any antibodies. Now we have the T cell data showing that the B cell and T cell go hand in hand. EDSPOR data. So I was not sure inactivated vaccines whether they really are going to stand the test of time. This is I think this was one of the first independent data from outside the manufacturers, and that's what you are asking for. And last thing is, which will be published in a couple of days, it is accepted in Annals of Rheumatic Diseases, BMJ journal. So what we have shown is odds of having an infection with Covishield versus Covaxin in a 1,000 patient cohort is 2.75 against Covaxin. Covaxin is having higher risk of infection. All this indicates that maybe we are having a wrong choice by choosing inactivated vaccines. And last thing, somebody asked me that very interesting data is that those patients who are having infection and after receiving the first dose of vaccine, if them give them second dose of vaccine, their antibody titers are falling, and even the neutralization titers are falling. This was a very surprising finding we found during our study, and I think this is extremely important because we are all boosting ourselves, and if we are having high antibody titers and we are boosting them, we are going to have, maybe it's a detrimental effect. I would like to hear your comment on that, why that's happening.
So I think this is really interesting data, and I'm so glad. I was really happy to see your prior publications, and I'm really glad to hear that you've continued to work on this and have extended this area, because I think we've become driven by an agenda where the narrative has so far been very controlled without independent evaluations. And what you're doing is really an independent evaluation. We need more of these. You've gotten to the point of immunogenicity. You are now adding in clinical information showing a higher risk of infection. It's very important to get it out there. Essentially, what this is going to show is that despite everything that we have said, maybe Covaxin isn't different from other inactivated vaccines. You know, we've been talking about the fact that it has a different adjuvant, and that's why it's supposed to be different from other inactivated vaccines, but maybe it isn't. And that's why this clinical information and independent evaluations become very important. You're aware that we are also doing a boosting study. We are still blinded. It's the, Covaxin arm has finished recruiting. So everybody is vaccinated, but we have not finished the follow-up for generating that data. I would not be too surprised to not see a large response in a third dose of what is a relatively poor immunogen. Because I don't know whether widening the gap would make more of a difference, but I'm not sure that it would necessarily result in a huge increase, which is discrepant from the data that the company has reported. So I think we just need to wait.
Ma'am, those who are having high antibody titers, if you give a booster dose, why is the fall in antibody titers, ma'am?
Oh, that's because they don't, you've reached a saturation limit for that individual. That's been seen for many vaccines, that you cannot boost beyond a point for certain individuals.
But does it come down, ma'am? Neutralization is also coming down.
Yes, with time, it will. Basically, the vaccine had no effect. And the decline is happening because that would have happened in any case.
Thank you, ma'am.
Thank you. Thank you, Dr. Shenoy. The question from Dr. Rajendra of Central University was related to adenovirus vector. We have already partly answered that. If neutralizing antibodies produced by Omicron infections give protection against other variants like Delta, will it give protection against on upcoming variants like the new flu? Just one.
We will find out.
Okay.
So we have no clue what the next variant is going to be and how much immune escape it will have. So we'll just have to wait and see.
Okay. Since most of us are infected with Omicron or Delta, the waiting period for the booster is 3 months now. Can we reduce that period of waiting for booster after a bout of positivity? Many countries are reducing the waiting period.
As I mentioned previously, I think if you've been vaccinated with 2 doses and infected, you probably don't need a booster.
Again, Dr. Arvind, pregnant healthcare worker, what should be the policy for booster?
Again, I think we are going a little overboard on boosters without sufficient information. So if the person wants to get a booster, sure, give it to them because they fit into the category that allows for them to get a booster. How much benefit it will have in that category, I'm still very unclear about. I know that pregnant women are in priority group 2, and as healthcare workers would come into priority group 1 for the WHO classification. But in general, healthcare workers tend to be reasonably healthy. And with 2 doses, I don't think that there is a specific subset analysis that shows us how much the benefit of the booster is.
Why are people getting COVID 3-4 times in spite of vaccination and getting natural infection too? Are they poor responders or non-responders or antibody rapidly declines?
How many times in a year do we get common colds? Some people seem to have a cold all the time. Other people almost never develop a cold, right? So susceptibility varies by individual. And respiratory infections, mucosal infections in general, you cannot have sterilizing immunity. You may have some level of genetic resistance to respiratory infections, but you cannot guarantee that this person will never acquire an infection with this or that virus. That it's not like measles, where 2 doses of measles, you can say, 99.5% of the population is never going to have measles. You cannot say that for a mucosal infection.
As massive infections are occurring with each variant coming up, shouldn't we focus more on treatment strategies like telemedicine?
I think there is a lot that needs to be done to strengthen our health systems, to increase access to people, and to ease our ability to be able to provide appropriate advice to patients. Telemedicine is certainly a big part of that, but not all of medicine can be done by telemedicine. So in terms of rationalizing our approaches, yes, absolutely, we can build better systems. If a response to SARS-CoV-2 is going to get us to build stronger systems, I'm all in favor of it. But we shouldn't ignore everything else because we are solely focused on SARS-CoV-2. You know, cancer has suffered, diabetes has suffered, everything else has not gone well because of our focus on SARS-CoV-2.
Dr. Seiru Philip, Professor of Community Medicine from Alleppey Medical College. We have bedridden patients at home cared by family and supported by volunteers. If these patients become symptomatic, that's fever, etc., which strategy would be appropriate? Testing and shifting to hospital, or giving them symptomatic treatment and good supportive care at home?
I would leave them at home because most people are more comfortable at home, but with much more intensive monitoring, and shift them when there are warning signs.
Okay, there are other waiting time questions from Dr. Reggie Mohan Gynec. We have already answered that. This time, I think there are some other questions in relation to, you know, people receiving other vaccines like the Johnson & Johnson from USA and coming back to India. What should be the strategy?
So lots of people have received mRNA, Johnson & Johnson, people in the Gulf have received inactivated vaccines. Go by the class of vaccine and the number of doses that you have received for your category, right? And for Johnson & Johnson, if you've received one dose, take another dose if you want of Covishield. I think you completed your primary immunization series with that. With the mRNA vaccines, take any of the vaccines that are available in India.
Shouldn't we have a policy to give a third dose to all immunocompromised irrespective of age and not just elderly? mRNA vaccines for the immunocompromised schedule as 3 doses plus a booster dose.
So we don't know about 3 doses plus a booster dose for immunocompromised individuals, but I completely agree that immunocompromised individuals should receive 3 doses of vaccine irrespective of age, because we know that in many classes of immunocompromised individuals, you need those 3 doses. I also think that we need to have more vaccine platforms in this country, including mRNA, so that we can offer all of these to people who need them.
What's the evidence available regarding the vulnerability to vaccination-induced allergies and anaphylactic reactions? Any specific categories affected more?
So right now, there is no data that indicates that any pre-existing condition, including severe multiple allergies, can predict an allergic reaction or anaphylaxis. This has been quite extensively studied with pharmacovigilance programs around the world. And the only contraindication from a safety perspective is an allergic or anaphylactic reaction to a prior dose of that product.
Dr. Srikumari, Professor of Obstetrics and Gynecology, have we formulated a vaccine dosage schedule for pregnant so that maximum protection is got during the 3rd trimester?
We have not. The current recommendation is to give pregnant women vaccine whenever they present, in conjunction with understanding whether they have received or not received a dose prior to their pregnancy. So, you know, the usual thing of giving a vaccine in the 2nd trimester, not being applied for SARS-CoV-2.
What should be the ideal interval of 3 doses in the immunocompromised?
I think for most vaccination, the longer the interval you have between doses, the better it is. But it does need to be titrated against the need to induce protection quickly. So for example, if you have a surge in cases happening outside, I would shorten the interval. If there is no surge in cases and I'm looking at how I can produce the longest lasting protection, then I would lengthen the interval. that in general, anywhere from 1 to 3 months between doses is a useful schedule. Other schedules that we already use for hepatitis B pneumococcal vaccine is 1+1, 1 month apart, and then the next dose after 6 months.
Dr. Manoj, when the test positivity rate is nearly 50%, should it be modify our testing strategy?
I think the only thing that 50% shows you is that you're not detecting all your cases. And we know that. We know that that is happening from the time that your test positivity rate is 10%. So you need to understand the purpose of testing for each category that you test and what you will do with that information.
Thank you. And finally, when will it end?
So is it, are we going to eradicate SARS-CoV-2? I hope we don't try to do that, because as we know, eradication programs can consume humongous resources, and we have other problems to deal with also. But in terms of thinking about waves and variants, we should expect new variants to arise. We have flu all the time. We have new variants of measles, everything, all viruses, especially RNA viruses, will continue to evolve. We'll continue to see new versions of those viruses. What we need to focus on is making sure that we track these variants when they happen. We make sure that we have good treatment protocols that are available for people, and we give populations the best protections that we have at any given time. And we live with the virus. There's no reason why we can't do that sensibly.
There are more questions coming up, but there are a few questions on monoclonal antibodies. We are actually reaching time. I'm sure you have some other meeting to join. Will there be time for answering that question on the monoclonal antibodies?
Sure. So I didn't show the figure on monoclonal antibodies, but essentially there have been really good studies that have been done looking at what's happening with all the monoclonal antibodies that have been developed, that were largely developed based on the D614G version of the virus, what some people call the grandmother virus. Now, of all the monoclonal antibodies that were developed, the only one that continues to work is the one that is from GSK, the sotrovimab, which is actually based, unlike all the other monoclonal antibodies. All the monoclonal, there are 4 classes of antibodies that bind to the spike protein. Most of them bind to very variable regions of the spike protein. But there is a conserved region of the spike protein, and sotrovimab binds to that conserved region. So that is the reason why sotrovimab continues to work, and all of the other vaccines, all of the other monoclonal antibodies that belong to different classes bind to the variable regions of the spike protein have stopped working against Omicron. So vaccine, the monoclonals available in India don't work.
Thank you very much. It was a really, I think the interaction was really very informative, and we have many more questions coming up. Hope you will spare one more session with us in the near future as it evolves. Thank you very much. Asha ma'am, shall we move to the next? Would you like to give a comment or
no, that's fine.
On Dr.
We're completely out of time, so yeah.
Okay. Thank you very much, Dr. Kang, as a leader in research. As you said, we have mostly academics. Actually, this session is jointly by the medical education and health services and the state training divisions. We have participants from both the academic training and the the district health administration. Actually, from Kollam, we are liaising with the district health and the state training division of the NHM in organizing the session. So it was a real, overwhelming experience to have you here interacting with us. We expect to work with you together. I think even at the research front, as you have mentioned, there is a big research gap, especially since Madam is also there. Madam is the leader from the medical education side. That research and data, we hope we work towards that also. Thank you very much, Dr. Kang.
Thank you, Indu.
As we move forward, you can actually stay back with us because the next session is on policies, and we have.
No, that's fine, Indu. Thank you very much. I do have to leave for another meeting now.
Dr.
Yes,
Khan,
yes,
let me
ma'am.
also express my thanks to you again for joining us. You have been the voice of sanity as far as Kerala is concerned over the last wave. So it's an absolute pleasure having you with us again.
Well, thank you, Asha, and call me anytime if you want to discuss anything. And same for you, Indu. Bye.
Bye-bye. Thank you very much. The panel discussion, Omicron wave in Kerala, challenges and solutions. We have Dr. Senia T. Nujum, Regional Field Cell Coordinator from GMC Kollam, moderating the session. The panelists are Dr. Ramla BV, Director of Medical Education Kerala, Dr. B.R. Raju, Director of Health Service Kerala, Dr. Thomas Matthew, Joint Director of Medical Education Medical Kerala, Dr. Reena KG, Additional Director of Health Training, Dr. V. Meenakshi, Additional DHS Public Health, Dr. Bindu Mohan, DMO Kollam, Dr. Sandeep, Deputy DHS Family Welfare, Dr. Sandhya, District Surveillance Officer Kollam, Dr. Santosh GS, Superintendent of Kollam Medical College, Dr. Aravind, Head of Infectious Disease, Trivandrum. Over to you, Senior.
Thank you very much, Indu Madam. Am I audible?
Yes, you are audible.
Respected Asha Madam, Principal, Rashid Sir, Indu Madam, and all the dignitaries who have joined us. Very good evening to all of you. I think the time now is 6:32, and I think that actually we were, this time is the time that we were planning to end the session. So, and as I see in the panel members, I've just looked through the participants and I see only 3 panel members here because the state RRT is going on. So, Madam, shall we just go quickly to the questions to the 3 panel members if I have missed anyone? So, first of all, welcome Thomas Matthew, sir. I had seen Thomas Matthew, sir, in the list of participants. Sir, you have been the leader managing the human resources in the state. And I very fondly remember the management sessions. Good evening, Edwin. Thank you very much for joining us. And we know how hard you have been working all these days, right from the beginning of the pandemic, drafting guidelines, running between hospital and the secretariat to do a lot of things. Thank you very much. Can you just tell us how the clinical scenario has changed during this wave in terms of the manifestations, the diagnosis and treatment? Is it different?
Good evening, Asha Thomas, Madam, and all my teachers and colleagues. As Senior Madam has said, the Omicron, the wave that we are facing now, from actually a clinical perspective, compared to a Delta wave, the severity is less. That we know the replication in the bronchus is more, and the replication in the alveolus is 10% less than that of Delta. But the challenge is with regard to the increased number of patients who are likely to get infected because of around 3 to 4 times more transmissibility and around 4 to 5 times more reinfection risk compared to Delta wave. If we are going by the Kerala data, around say 0.4% of the patients during the current wave are getting into the ICUs compared to say 1.5% during the Delta wave, and around say 0.9%, 0.8% is requiring oxygen beds compared to around say 2% during the Delta wave. And even though the hospitalization, the conversion rate is to the tune of 3%, that is mainly because of the other factors like CKD and all those things. So as far as the managing Omicron is concerned, Delta, we had adopted a different strategy because at that point of time, Delta being a more virulent virus, the hospitalization was more, there was, a run for the ICU beds, oxygen beds, etc. And across the country also, there was a scarcity of resources, right, from oxygen, remdesivir, tocilizumab, etc. So our plan definitely was to sort of plateau the peak so that we will buy more time. And in that, we sort of succeeded in spreading the Delta wave over the next 6 months. It ensured that none of our patients died without ICU care. We were never out of resources like oxygen or remdesivir, etc. But with regard to Omicron, since despite having around 55,000 cases per day, our ICUs are not really full. So that is the reason why we can be a bit more. We are not really trying to flatten the peak or anything. We are just going by the conversion rate and in the category C districts we are approaching a syndromic approach is being taken. But having said that, we have around say a large population of vulnerable. For example, above 60, second dose has been administered to 92% of the population. That means that 8% of the real vulnerables are not really fully vaccinated, and that in Kerala might translate to a huge number. So our focus has to be on that. And regarding the clinical manifestations, even though we say that the requirement for oxygenation, etc., is less, Omicron to an extent is not really mild as far as the symptomatology is concerned. The people are having say high-grade fever for 3 to 4 days, excessive fatigability, headache, sparking cough, and all those things. And in pediatrics also, more symptomatic children are presenting. They're having febrile seizures, then croup-like etiology. But these sort of manifestations are not really translating to ICU admissions or oxygen requirement. So as far as those numbers don't go up, we will be able to tackle this way.
Thank you very much, Arvind sir. And the very useful information that we pick up from there is that in Kerala, we need to have a strategy where we'll focus on the unvaccinated elderly. Is that right?
Yeah, it means we have to catch up with that 8% of people above 60 who are yet to receive their second dose of vaccine.
Okay. So also that is very useful information that you said that around 0.4% of patients come to ICU as compared to 1.5 previously. So I think that figures maybe we can use for planning our hospitals, the number of ICU beds and all those that information that you shared with us is very valuable. The 0.4% in ICU and 0.8% requiring oxygen beds, right? Thank you, Arvind, very much. And the next question to you is that I've heard you speak a lot about the home care. I think you are the most important person taking all the sessions on home care. So could you tell us some of the areas where we think home care needs to be made a little better in this current
definitely, madam, because our policy is always to keep on improving, that we don't want any patient to die at home. We don't want any patient to die in transit or within, say, 72 hours of hospitalization. During the Delta wave, if you look at our figures, around 8% of our patients during the Delta wave peak died at home. And some people died in transit. And within 72 hours, if some person is dying within 72 hours of hospitalization, that means that the patients are presented late to the hospital. And if you're looking at the district-wise split up of home deaths, we can arrive at some conclusions. In certain districts, the home deaths are actually more. So we need to focus on such districts and need to find out what is happening there. We did do an sort of an OR in late percentage to our hospital. The interesting things that came out of that OR was that when they contact people during the Delta wave peak, they chose to remain at home. Elderly and those with comorbidities, etc. By default, they remained at home. And when they contact this e-Sanjeevani or say the nearby PHC, etc. So our focus was always on the red flag signs. We expect them to be thought about the red flag signs, the importance of pulse oximetry, the importance of 6-minute walk test. If they don't have access to pulse oximeter, the single breath count, etc. But instead, what they got was the paracetamol with azithromycin and vitamin C add-on. So these patients end up taking these medicines thinking that they won't progress to severity because of these medicines. On the one hand, it is actually a misuse of azithromycin, which might lead to an increase in antimicrobial resistance. On the other hand, it is giving a false sense of security to them. So during the current, we have been engaging with the NHM to correct this anomaly. We have been engaging with the e-Sanjeevani platform, and also the doctors who are answering the calls over phone. The focus has to be on teaching the people in home care about the red flag signs, not about management. Supportive management is just paracetamol, CPM, and like that. So we should not be giving azithromycin. We should not be giving a false sense of security. This is one area we can actually really focus on, because the 8% people dying at home or in transit, etc., is not really very good figures. We have to improve on that. And during this wave also, 97% of the infected are at home. And because of the epidemiological vulnerability of Kerala, 20%, 25% of us being diabetes, hypertensives, around say 50 lakh above the age of 60 and all, there are going to be vulnerables at home. So we need to reach out to them, and we are using all platforms, because this time around we are using the social media platforms and all. Last time we were focusing on, even though we are having 3 levels of monitoring. One is through the telephonic platform, that is the PHCMO is supposed to reach out to them, e-Sanjeevani is supposed to reach out to them. Second is actually self-monitoring for the red flag signs. Third is actually self-monitoring using the pulse oximetry. But then when the numbers really went up during the Delta wave, the first component is really broke down. That is, we were not reaching out to them. So we need to focus on the second and third component. That is, even if we are not reaching out to them, they should take care of their health. That is the self-monitoring. So we are focusing on that. So relying on just ASHA to give the message to them is not going to work. So we need to reach out to the public through all the platforms, and the state has been doing that. We need to teach everyone in home care about the red flag signs, when they should reach out to when they should seek help, etc. And based on the division of the home care death among the different districts and the delay in presentation, because we have the data with regard to in which district there has been a delay in admission and which resulted in death, etc. We should have plans pertinent to different districts. It's not like, say, blaming them. Our aim is to prevent even a single home death.
Okay, thank you very much, Arvind. That was very useful information, and I understand that the state is actually focusing on what you were telling, that is on giving targeted education to focus on the empowering people. And we know the people of Kerala are very educated, so empowering them to reach the hospital at the earliest in case of identification of the red flag signs. So that is very important. Thank you for the message. I hope all the participants, they are very important for people working in the different parts of Kerala, will take this message, and I hope that this focused action will happen. And also what you said about the OR that you did, and that showing the disaggregated data, maybe that has to be continued in the present wave also, to identify what are the risk factors of late presentation to hospital and mortality. So thank you very much, Aravind. One more last question to you. What are the strengths of the hospital staff? You have been interacting with the hospital staff all the while, and we know that the HR that we are seeing in the current wave is not the one that we had in the beginning of the pandemic. At the beginning, we were all very energetic, and it was the first time we are facing a pandemic, and we're working so enthusiastically. Now that we have gone into years, I think most of them are burned out as well. And so what is the strength of the hospital staff that keep them going? Can we build on that strength and address, or what should we do to keep them going?
Actually, madam, it's a very difficult question to answer, but the positive side is that of the states or places in the world to work for a healthcare worker, one of the safest places will be Kerala. There is no doubt about that. Because, if you look at the healthcare worker mortality across the globe, in Kerala, I'm talking about the healthcare workers below, say, 62 years old. Okay, not the 70 years, 80 years healthcare workers. Our case fatality rate is 0.06. Okay, so it's very difficult to match this number. So healthcare workers know that they are taken care of by the state or by their own institution, because even during the Delta peak, we were taking care of all the healthcare workers who got admitted, were admitted in their own institutions, even their loved ones. Admitting a healthcare worker alone is not the answer. Even their and the loved relatives, etc., we were taking care of them. So the healthcare worker mortality being the lowest, that definitely gives them a sort of courage. Now the healthcare workers are not really frightened that they are going to die. Their issues are with regard to the last 2 years they have been in PPE. The work-life balance is not going like that. Then psychosocial stress, etc. during the first wave, the second wave, the first wave, the problem was with stigma. So because they had to be isolated in different areas, etc. But what Delta did was, because of rampant community spread, everyone got infected, and that stigma went away from the healthcare workers. So they could mingle with everyone like that. This Omicron wave means the stigma aspect is not there for the last 1 year. That is actually a blessing for the healthcare workers. During the Delta wave, more people were concerned about the increase in mortality, but then that we were very successful in taking care of the healthcare workers. We were able to vaccinate all the healthcare workers at the right time. With the Omicron, the real problem is with regard to, they have been working for last 2 years, and isn't there any escape from Omicron and all those things. But then it is not by chance that the healthcare worker mortality in Kerala is zero. It was because of planning only. Because if you are looking at our policies, Kerala was the only state where we had been sticking on with the N95 right from the beginning. That's from April 2020, when all the guidelines, the CDC, NICE, the WHO guidelines were saying that you need to use N95 mask only when dealing with aerosol generating procedure. Kerala never changed. Even ICMR did say that when you are going to a patient with COVID-19, you can wear a triple layer mask. At that time, it was like that. But Kerala stuck on with the N95 mask. Another aspect is, even prior to WHO saying that even the asymptomatic need to wear the mask, Kerala government came out with the guidelines 2 months prior to the WHO directive. And because of the widespread use of the high quality N95 mask, etc., probably the viral load was less. And that case fatality rate of 0.06 really reflects the care that the government did extend to the healthcare workers. And now it is more about the burned out. That is to be expected, not only in Kerala, in the rest of the world also the burned out is there. And I think the students are the ones who have suffered the most rather than the healthcare workers, because their curriculum, everything got totally destroyed. Not only our medical students, the school-going children as well. These are the the advantages with regard to what the state did to healthcare workers. The other side of it is also there. Majority of us are really, majority of the healthcare workers are really burned out. I don't know the solution for that, because after Omicron, the pie is going to come, and it's going to be an ongoing process. And probably because of vaccination, hybrid immunity, we need to, just like what Spain said, fluidization of, considering it like flu. Probably we also will have to reach that stage.
Okay, thank you very much, Arvind. That is very reassuring from your part to tell us that we are in the safest place of Kerala.
Hello? Madam wants to ask a question.
Yes, madam, please.
Dr. Arvind, I've been thinking about this for a while now. Maybe I should have asked this even when Dr. Kang was here. If people who actually had an infection, I've really got COVID and I've recovered, I'm coming back to work, do I really need to wear a PPE kit anymore?
Madam, actually, we have actually moved away from PPE kits. WHO says that we need to put on only a surgical gown, but we need to focus on our N95 mask and eye protection.
So actually, our healthcare workers who are now working in COVID wards, do they need to wear PPE kits?
No, PPE kits are not necessary, madam. The N95 mask, the face protection, plus the surgical gown. Even the headgear and the shoe cover, etc., the CDC have taken it away. And in the state also, around 7 months back, did come out with a guideline saying that it's up to the institution and up to the person. If they are really afraid, they can use the PPE kit. Otherwise, they can stick on with the surgical gowns. We are using surgical gowns only. But if you are working in an ICU environment where all sorts of aerosol generating processes are going on, probably that is one situation where you can put on the PPE kit.
Thank you, madam, for that question. Are there any more questions from you, madam? Would you like to ask him anything more? No. Thank you very much, madam, for that question. And we are happy that you interacted. And thank you very much, Arvind. I know that we can talk on because you have such an experience in this field. But then let's now move on to our next panelist. we have Dr. Reena KJ, additional DHS. Madam, are you there? Madam was previously in charge of public health. Okay, that's fine, madam. But thank you very much. After the state RRT, you joined us. We are very happy for that. She was previously in charge of public health, and now she's in charge of training. And with her vast experience, some of the questions I'd like to ask you, madam, since you are dealing with the training and capacity building, what do you think? What are your plans for enhancing the capacity of the system at present?
At present, we are working with the inside the system as well as outside the system. First priority with us is to teach all the staff as well as RRT members and general public about the do's and do nots in the home isolation period. We are doing that vigorously, about 6 sections from 3 notes daily. We think that we will be able to complete it by the February first week. Then we are planning to do some massive psychological support system to our staff who are actually burned out. And I don't know how to handle it, as Dr. Aravind already said. Anyway, we are trying to do something.
Okay, madam, that's great to hear, especially when Aravind sir was telling us about the need for that. And another thing is, madam, is you're a microbiologist also. So would you like to tell us what is, was he in the previous presentation, Dr. Kang, madam, was telling us that 95% of the viruses are Omicron. So what are the plans for the state in looking into the genetic epidemiology of Omicron? Or of
Madam, I am not sure about it, madam. I am not sure about it because now I am purely dealing with the academic, administrative thing and training. I can't say anything about microbiological aspects of Omicron and as well as vaccine, as well as how we should deal with that.
Okay, madam. But do you foresee any challenges before you as the leader of the capacity building team, madam? What are your challenges? Any challenges? Okay. Any other things that you'd like to share with us regarding the burden and other things? Because the other DHS and additional other public health additional DHS, Meenakshi madam is not there also. So would you like to share anything about the burden?
Already the state officials are burdened like hell.
Okay, madam. Thank you very much.
Do our work as well as we are in charge of our district. So it's dual action.
Okay, madam. Thank you very much. And for joining, if there are, do you have anything else to share, madam? Shall we move on to the next panelist?
If possible, can I get the recording of the sessions?
Yes, madam. Definitely we'll share with all the participants. We have another our panelist is Dr. Santosh. Santosh sir, are you there? Santosh sir is the superintendent of Government Medical College, Kollam. Sir, are you there?
Yes. Am I audible?
Thank you very much, sir, for joining. Sir has taken charge of as superintendent very recently, but despite that, is very active at our hospital. I feel you're the right person to tell us what are the preparations in the hospital for the current wave. And as an administrator, like you must have been interacting with other administrators of hospital as well. Could you tell us the most important challenges that you face and also suggest some of the ways to get over it?
Madam, the main problem I faced, because I took charge on October 18th and on October 31st, the COVID brigade was dispersed. And actually, in Kollam Medical College, the shortcoming is mainly we are having no house surgeons and no PGs. Only up to final year students we are having. So we are having only 120 staff nurses and cleaning staffs, and we are having junior residents and a dedicated team led by the deputy superintendents, RMO, and we are right now having a nodal officer for COVID, Dr. Benny. He is doing a very good job. And assistant nodal officers are there, Dr. Neelima, Dr. Ranam B. Modi, and Dr. Prashop, and infection control nurses. These teams look after all the aspect, and we yesterday we made a COVID control room and we are assessing the situation. The main problem right now we are facing is the infectivity or positivity among healthcare workers. today our RMO and healthcare health inspector became positive, and many of our JRs are positive, and many faculties are positive, staff nurses are positive, and the main problem right now we are facing is the healthcare workers positivity, and our district administration and NHM is supporting, and we are conducting interview for persons from COVID brigade next week, and we are planning to, or we are allotted 12 junior residents and staff nurses and cleaning staffs. And when these people come by next week, we will be able to fill the gap which is made by the healthcare worker positivity. And the logistics, and one important thing I have to mention about is the KMSCL support. Leena Madam is the charge of the KMSCL unit at Kollam, and our store super, Mr. Ashraf. Both of them being very helpful. So as of now, we are having no logistic issues. And our microbiology HOD Geeta Madam and her team with the RT-PCR lab is doing a very, very commendable job. And the infection control nurses, Anup and Lisha, they are doing a very good job. And we are taking these infection control practices, and the lack of cleaning staff is what we are facing, that challenge what we are facing, and that will be somewhat reduced by the recruitment of 20 cleaning staff by next week. And these are the main things I have to tell. And once again, I thank the district administration, especially DM and the district collector, for making this support to us by opening the Nedungolam. Nedungolam they opened with 30 beds, oxygen beds, and Asramam Hockey Stadium they opened with 60 beds. So actually, we are having only 15 ICU beds. But when the staffs comes, these and these staff nurses come, we are planning to open more ICU if needed. We are having escalation and de-escalation plans, definite escalation and de-escalation plans as per the situation, and as the situation warrants, we will move into the next phase.
Thank you very much, Santosh sir. We see a very effective manager in you, in spite of the HR shortage. The way you have applauded the HR that is already there, the support is a very is to be appreciated, actually, sir. And we learned from you. Thank you very much, sir. Is there anything else you'd like to share? Shall we move to the next panelist?
And one more thing I forgot to mention. It is the 101% support from the respected principal Rashid sir, which made me do these little things. I sincerely thank him. And also,
we are all part of the team, sir, and I think we don't need separate acknowledgements. But it is, thank you very much, sir. Shall we move to the next panelist? We have Indu Madam with us. Madam is also part of the panel. Madam has been very effectively part of the entire planning of COVID scenario, especially the surveillance. She was the state feed cell, she was in charge of the state feed cell earlier. We are proud to have you as a leader, Madam. And Madam, could you tell us how we could strengthen the surveillance in the current context so that it's beneficial for action? She is also a mental health expert. So would you like to tell us anything about how to deal with the psychosocial issues as well among the people and the healthcare workers?
Senior, I'll quickly take up a few questions from the chat box also. Regarding surveillance, I think Dr. Kang also used to acknowledge. I think everyone at the national level also used to acknowledge the surveillance system, because the way the Kerala second wave was plateauing off, the numbers were never touching baseline, right? So that was reflecting the number of tests and the surveillance. But regarding the present scenario, how much of it is Omicron, how much of it is Delta, the overall, Dr. Kang was mentioning 95.5, the global, I think WHO is 89.11. Whatever it is, right, we may not exactly look at, the exact numbers, but the trends are important. Even today, the positivity stays at 46%, and we have around 3.4 lakhs cases. So it's not the exact numbers that we get, as definitely there will be more cases. So I think from the surveillance data, what we get is more of a trends once the numbers have gone up and the proportions have gone up. And the objective is to reduce mortality, as Arvind was mentioning. Like, it's really important that we pick them up early. As we were going through the appeals in the COVID district death audit committee, right? So much of deaths have taken place at home. So only 3.5% of the total positives are there today within the hospitals, and the remaining are. So it's really important. But for I think even today the deaths are not that high, but the coming days are also really important. So beyond the numbers, I think these are the trigger points and the surrogate indices that we have to look at. What is happening in the hospital, so those kinds of audit. Dr. Kong was also mentioning about, the research. So surveillance, though we say the data is surveillance, a lot of research. See, surveillance is for action. We say identifying sparks. So what if the next, I think the real trigger has to come up a little earlier, even before the real, numbers really go up from the trends itself. Like, the cases are going up, but the hospitalization rate is not going up. So there might be transmission happening. Those kinds of interpretations from the surveillance data will help in policy making and more effective risk communication. When so much of a huge proportion remains at home, it's really important that we tell people, especially with the huge social capital that Kerala has, it's really important that we interpret the surveillance data and tell people in advance that the surge is coming, just even before the surge really comes up. And regarding some of the questions surveillance data and research, actually research is advancing knowledge. The surveillance data itself, for example, every day, Asha Madam is also there, super and principal, many of our colleagues from the medical education. So every day we are sending reports. So look at determinants of mortality within hospital, determinants of mortality within ICUs. So large databases. I think publications do help in advancing research. The first immediate objective may be to decide policies, Definitely evidence-based policies are important. But at the same time, it's equally important that we come out with advancing knowledge, which is really possible with the kind of data that Kerala has. So that is one thing. Not exactly surveillance. Some of the our surveillance data, especially the data from the hospitals, have lots of variables that can estimate risk of several important outcomes. I think there's a question. There is a comment.
Before going to the next question, let me say one word. See, we are doing lots of research work, but it is not appearing globally. That is what the madam said. So there should be a measure to coordinate all our activities or all our research work, and that is to be projected globally. Then only people will understand that we are doing this much of work. Otherwise, we are doing a lot of work, but there is no evidence for that. So I think you should do something for that.
Agree, sir. So it's a matter of writing protocols, getting ethics clearance, and getting it published so that evidence gets generated. Thank you, sir. So regarding Dr. Santosh said, regarding the human resource and the house surgeons and postgraduates, actually all the major medical colleges in Kerala, the role of junior doctors, the interns, the house surgeons, and the postgraduates. I think Dr. Shafiq has kept a comment in the chat box, which is really important, right? Acknowledging them, appreciating them, the real, the burden, right? The hospital burden, the care burden was borne, to a great extent by them. So that kind of an appreciation is what. And regarding the burnout also, but definitely we need strategies to address that. Burnout of among all healthcare workers, those working in critical care units, nurses, the nursing staff. I think the way the nurses run the hospitals is during the COVID, not only medical colleges, all hospitals. So the JPHMs, the way we conducted vaccinations, India as a country and within the state, though when Kerala achieves such a high vaccination coverage, that is one of the largest strengths for Kerala to face this surge, right? Our probably the highest immunization coverage. So, and definitely these the changes in strategies based on the surveillance data. Dr. Manoj again puts a comment on like when the positivity goes up, is there a need to segregate COVID? And definitely we have to, have policies based on the data as it evolves, because the situations are changing, and as we know, the non-COVID cases, and there is the way it suffers. Okay, and there is Aravind there to answer a last question on a indication, any contraindication for Etorecoxib during Omicron infection, as fever and body pain is usually refractory to paracetamol. Aravind, are you there?
Instead of Etorecoxib, it will be better to try naproxen as per the national guidelines, or mefenamic acid. We are using naproxen or mefenamic acid, especially for the severe sore throat, which is not coming down with paracetamol alone. It's better to keep off Etorecoxib.
Thank you very much, Madam, for highlighting the importance of research and surveillance going hand in hand with research. And Kang Madam was also telling about the importance of linking the different databases and trying to derive meaningful information from that. So I think that was a very important answer from you, Madam. And also thank you for uploading on the all categories of health staff. I think the field level health workers, especially the JPHNs and ASHAs also need a special mention, because they have been working tirelessly all through the COVID pandemic, especially in terms of the vaccination efforts. The JPHNs have been taken a huge effort, I think. So, so shall we close? The time now is 7:07. I don't see any other panel members. Madam, shall we wind up the panel with your permission, the permission of Asha Madam, and with the principal's permission? I'm ending up this panel session. Thank you very much to all the panelists, Arvind sir, Reena Madam, Santosh sir, Indu Madam, and I've seen many eminent people also among the participants who are actually eligible to be panelists and worth asking questions. But because of shortage of time, I'm not going to each and every one of you. Thank you all for participating. And let me wind up this panel session with a key message from taking on from what Kang Madam said, that we will all learn to live with COVID, at least in the near future. Maybe we will adapt with the virus and the virus will adapt with us, and let us hopefully hope that in the near future we will go in peaceful coexistence. I'm handing over to the Madam. Thank you, Madam.
May now invite, thank you, Senior. I must, the formal vote of thanks will come from one of the chief organizers from the State Training Division of National Health Mission, Dr. Divya. She's the State Nodal Officer of Training.
Honorable Additional Chief Secretary Health, Family Welfare, Dr. Asha Thomas Madam, and Honorable Principal Secretary who agreed to join and he couldn't, and respected DHS who also agreed to join but couldn't, and respected DME, joined DME, additional DHS who joined, and all those who supported, all the additional DHS and joined DMEs who supported us, and the Principal Kollam sir and Indu Madam, all the team from GMC Kollam, and dear all participants. The responsibility that is actually entrusted in me is to say a formal vote of thanks. And though the RRT was going parallelly, I couldn't completely enjoy the session, but it was partly I was also hearing everything here and there, but it was very wonderful a session, and I am very happy to be a part of this organizing team. First of all, I would like to express my gratitude to our chief guest, Dr. Gagan Kang, who actually being a very busy and very renowned person who was able to spend a few hours with us, explaining everything to us, answering everything to the participants who asked the questions and their doubts. Thank you, Madam, for being there with us and expressing all the thoughts that was actually very valuable for all of the participants. And next is our own team. Our own team leaders. I would like to thank our Additional Chief Secretary, Madam, Dr. Asha Thomas, Madam, for being there with us, guiding us, and involving through and through in all and each and every sentence that was uttered in this discussion. And I haven't seen any of the policymakers who could actually be with us with so much of time. Even in the first discussion also, Madam was there with us discussing each and every points. Thank you, Madam, for being there for us. And thank you for actually guiding with all these opportunities. Then I'd like to thank our Principal Secretary Sir, DHS Sir, who actually, DME Madam, who were all actually part of the team, but who couldn't join, but they were all actually supporting when we introduced the idea of this CME session, this interactive session with them. Then I would like to actually thank Joint DME Thomas Matthews Sir, then the Principal Kollam Sir, then the entire GMC team for actually arranging this session, coordinating it well, and making it a very beautiful piece of academic work that will be worth reference. I'd like to thank all the eminent speakers and panelists, including Aravind Sir, Reena Madam, Iqbal Sir, and Senior Madam, everybody who actually shared all the bits and pieces of knowledge which is actually very important for their healthcare team. Our important team is the participants. Actually, this is a very difficult time for the participants to join because they might be traveling after their day's work. But we could see almost 210 participants in the screen, and that is a very encouraging activity. And we could see the chat flooded with questions. And thank you, team, for being there with us. Encouraging us with all these very sensible doubts, questions, pieces of thought, etc. And I would like to also thank the NHM Training Division, Mr. Nitish and Srijit, who's actually supporting us with the Zoom, the technical partners. I am actually winding up my thoughts. Thank you all.